Hello everyone. The trochlear nerve is a very small diameter nerve that innervates a single muscle, the superior oblique muscle. Now, here's a patient who had trochlear nerve symptoms secondary to an infarct in the region of the trochlear nerve nucleus. We can see on this diagram that the nucleus of the fourth nerve is, again, like the third nerve, just anterior to the periaqueductal gray matter. And we can see on the diffusion there's abnormal signal in that location. Here's another patient had trochlear symptoms, and again we see a small infarct in the appropriate region for the nucleus of the fourth nerve. Here's another patient presented with a trochlear nerve palsy. What's the possible etiology here? Anybody? Anybody see anything? I see no responses in the chat box. Can anybody hear me? Okay, let me proceed. This was a patient, as you can see, all the arrows pointing to multiple small cavernomas, and this was the region, there was a lesion in the region of the trochlear nerve nucleus. What's the cause of this abnormality that presented with their fourth nerve symptoms? Correct. Eric said multiple sclerosis. This patient had multiple lesions, with the largest one in the region of the fourth nerve nucleus, just anterolateral to the aqueduct. Now, you may recall this diagram when I talked about the cortical spinal tract as they descend from the cortex all the way down to the cord. The cortical bulbar tract travels with the cortical spinal tract, and the fibers, as they come to the level of the various cranial nerve nuclei, cross over to the appropriate location of each nucleus of the various cranial nerves. There's only one exception. The trochlear nerve does not cross over in the medulla or in the brain stem. That's the only cranial nerve that the crossing is at the lower motor neuron level. And as we can see in this diagram, here are the two nuclei of the fourth nerve. They then travel posteriorly, really the only nerve that travels posteriorly, and then at the level of the inferior colliculus, they decussate or cross over, and then they exit on the posterior surface of the brainstem, as we can see in this nice diagram by Netter. These are the two trochlear nerves as they exit just below the inferior colliculus, and then they will travel in the cistern anteriorly around the brainstem. And beautifully on these thin T2s, we can see on this sagittal image, here's the inferior colliculus, and here's the fourth nerve just below it. And we can see also in this coronal image, this is the inferior edge of the inferior colliculus, and here's the nerve, both nerves traveling below that. Now it's very hard to visualize the fourth nerve on routine imaging. It's such a tiny nerve. It only has about 2,000 fibers compared to the optic nerve, which I think has about over 1 million or 2 million fibers. So you have to work very hard to at least see, maybe like in this case, you see some segments of the fourth nerve. And here it is in the diagram, but we never really can catch it completely. However, the Europeans, with their high-quality cranial nerve imaging, demonstrated very nicely here. We can see at least a portion of the cisternal fourth nerve around the brainstem, both on the axial and again on the coronal plane, traveling laterally here before it turns anteriorly. Now, a very important landmark to identify this portion of the cisternal fourth nerve is this structure here, which is the superior medullary velum, outlined with a black arrow. This is like a very thin layer of white matter that covers the fourth ventricle. It kind of sits between the two superior cerebellar peduncle. So here it is here on the coronal view and on the sagittal view. And you can see this little triangle here. This is the superior medullary velum. Now, I was always frustrated because I could not demonstrate the nerve very clearly. So I finally found a thin T2 study, and as soon as I found this triangle, the superior medullary velum, here's the nerve on one side. You can see a little bit of it on this side. Even on the coronal plane, you can see it. Here's a nerve. The problem, there's always branches of the superior cerebellar artery, so you have to be careful not to mistake it. And again, here on the coronal plane, here's the nerve and one of the branches of the superior cerebellar artery. So that's the key, to identify the superior medullary velum, and then on thin T2s you can identify. Not as good as the European, but getting close. And again, we have to use one of those 3D sequences to be able to see the fourth nerve. Now, what are the findings in trochlear nerve neuropathy? We have vertical diplopia, difficulty descending stairs, and the head is tilted to the opposite direction. And many children are diagnosed with torticollis, which is actually just the turning the head to be able to see better. As you can see in this diagram here, and the normal, with the head turned, notice the horizontal planes in both eyes. However, in the patient who has paralysis of the superior oblique, notice the tilt in one eye, and this tilt is corrected when the head is tilted, and then this eye becomes also horizontal. So that's why these patients will walk around with kind of a tilt of the head to help their vision. Now, there are multiple reasons for trochlear neuropathy: congenital, traumatic, herniation, sometimes post-surgical complication, patients who had meningitis, post-viral syndrome, small vessel disease, especially in diabetics, and sometimes tumors. Now, the congenital, this is a paper published in AJNR this year from Korea, from South Korea. They had over 100 patients who had congenital abnormalities of the superior oblique muscle. And because of the difficulty in visualizing the nerve, they decided instead to look at the size of the superior oblique muscle. So this is the normal. And they found that a large number of these patients have much smaller hypoplastic superior oblique muscles. And they find a high correlation with the size of the muscle with the abnormalities, atrophy or absence of the superior oblique, of the trochlear nerve. So this is what they're using instead to diagnose these, mainly children, with abnormalities of the trochlear nerve. Now, one of the things that was not pointed out in these pictures is this dark line. This is the tentorial edge that I highlighted with blue arrows on either side, as you can see in this diagram. So here's the nerve between the brainstem and the tentorial edge. It's the tentorial edge which doesn't really give, which is the problem. Like in this specimen of a patient who had severe trauma, and we can see the contusion and the damage to the peduncle on this side. And I don't know if that's the nerve, but there's a structure which could be the nerve. So you could see when you have herniation and compression of the brainstem against the edge of the tentorium, how the trochlear nerve could be damaged because of its location right next to the free edge of the tent. So this is one of the causes of symptomatology in traumatic injury to the brain. Anybody know what this structure is on this plain film? I see people typing, but no words yet. Anybody? Well, it's not too many people look at plain films anymore. This is the Pietro Clinard ligament, which sometimes ossifies, and that's why it's visible. Just you don't think it's something you don't have to pay attention to. We can even see it on a CT here. It's a ligament that runs between the petrous apex and the posterior clinode, and you can see here it's calcified. The issue here is that here's the ligament, and the trochlear nerve, as it travels towards the cavernous sinus, passes right over this ligament, which is outlined here, and you can see why there would be trauma or damage, again in herniation or contusion, to this nerve as it gets banged against the petroclinard ligament. Okay, what do we see here? Correct. Eric and Gino mentioned schwannomas, and what we see here is this enhancement. So again, this is in the location of the trochlear nerve. And if we look at the coronal plane, even on this anatomic, where many structures are outlined, the fourth nerve was not outlined. Maybe this is the fourth nerve. Just because it's so tiny, it was hard to identify it. But here we see the enhancement and the enlargement and the appropriate location for the fourth nerve. Here's the trigeminal, which doesn't enhance. And this was never operated on, but was considered to be a schwannoma of the fourth nerve. I could not get any history on that, but the patient underwent gamma knife and the lesion apparently disappeared after the treatment. So again, the schwannoma both on the axial and the coronal plane. Here's a patient, NF2, massive meningiomas, lesions in both internal auditory canal. And then there's this lesion here. The question is this a schwannoma of the fourth nerve, or is this a tiny meningioma right attached to the tentorium here? It's a real dilemma. This patient had many issues with the meningioma postoperatively, in EPIC, there was no mention of and no focus on the fourth nerve, but this could be either a schwannoma of the trochlear nerve or a tiny meningioma. We can see again on the sagittal plane, here's the trigeminal nerve, and here's this lesion attached or next to the tentorial edge. And on this anatomic diagram, this is the tentorial edge, and the outline, this tiny structure as being the fourth nerve. Here again is the trigeminal. So in this case, we don't really know, is this a tiny schwannoma or a tiny meningioma attached to the tentorial edge? Here's a patient from the literature, NF patient, had bilateral trochlear nerve palsies, and we see schwannomas involving both trochlear nerves. Again, it would be in this location on both sides. Here's some more cases from the literature. These were two epidermoids, beautifully demonstrated. Again, on the normal, we see the trochlear nerve, at least in portion, and here are the two lesions. And this patient had trochlear nerve palsies. This was an ependymoma met. Again, it did not mention in the article if there were symptoms or not, but you can see how there would be symptoms because of this location right next to where the fourth nerve is running. And here it is on the sagittal plane. This was a patient who came in following trauma and had this small hematoma in the appropriate location, and I was hoping that at least there would be some evidence in EPIC of fourth nerve symptoms, but there were none. So like many literature cases, there's a lesion, but not always fourth nerve symptomatology. But this, you can see, is an appropriate location where the fourth nerve would be running. What's the finding here in this patient? Correct. Eric already pointed out that this is a lipoma seen on the MR sequences. And here it is, verified on CT. And this was a small lipoma. Again, no symptoms of a fourth nerve palsy. And this was another lipoma. Again, no evidence of fourth nerve symptomatology. This was an interesting case that came in and then after one study disappeared, so there's no history at all if the patient had symptoms or not. So anybody see anything? Right side, as Nate says, there's a lesion on the right side. Here's some more imaging. Any possible diagnosis? You have no diagnosis, just a presumptive diagnosis. As Asif said correctly, it's likely a cystic schwannoma, as you know, which is, you know, has this kind of typical appearance with the rim enhancement. And, you know, at the time when the study was read, a broad differential was made, infection, some sort of malignant tumor, but eventually a study from before, an outside study was put on the system, as we can see that 11 months earlier, the lesion looked exactly the same. So I think a malignant, highly malignant lesion or an infection was not likely, and it's likely that this was a schwannoma of the trochlear nerve, but patient was lost to follow-up, so we have no more information. So again, likely a cystic schwannoma of the trochlear nerve on the right side. Again, showing where it would be. Here's the course of the normal nerve. This was a very interesting case. This patient presented with symptoms called superior orbital muscle myokemia, which are repeated tics. They're secondary to a vascular conflict. You know, as we have trigeminal neuralgia, hemifacial spasm, or due to a vascular conflict, here's the trochlear nerve and the vessel, a branch of the superior cerebellar artery, right against it, causing this patient's symptomatology. And here's another case where we see the vessel, again a branch of the superior cerebellar, right next to the nerve. So again, superior oblique myokemia is a unilateral paroxysmal rotatory nystagmus. There's intermittent contraction of the superior oblique muscle. For some reason, it's 80% right-sided. And again, its proposed etiology is a vascular compression at the root entry zone of the fourth nerve. Okay, here's some possible lesions that may be associated with trochlear nerve symptomatology. Here's a large pineal region tumor, an aneurysm of the vein of Galen, and here's an arachnoid cyst. This patient definitely had fourth nerve palsy. And we can see why if we look at the axial images. Here's a large cyst, and we can see that the cyst kind of butts on the back of on the collicular region here, and you can see why the fourth nerve may be compressed by this arachnoid cyst. Again, it would be, see, here's the cyst, and here's the inferior colliculus, and remember the nerve comes out right over here. So that explains why the patient has the palsy. Okay, what am I showing in this case? What is the arrow pointing to? I would say 99% of the people look at these cases do not know what this structure is. There's something called the suprapineal recess of the third ventricle. Here's a large calcified pineal, and this is a posterior extension of the third ventricle called the suprapineal recess. And if we look at this ventricular picture here, so this is the third ventricle, massa intermedia. There are two posterior recesses, the suprapineal recess, and then there's a small pineal recess. So here they are. Normally, you'll see a small suprapineal recess, two larger ones over here. Now, these suprapineal recesses, especially in cases of hydrocephalus, can become massive. As you can see, these various diagrams here of the suprapineal recess. And here's a patient, an MR that we have, a 3-day-old patient had enlarged ventricles, and notice the size of the suprapineal recess. It's not an arachnoid cyst, it's just the suprapineal recess, which is prominent. Here's a patient who had shunted hydrocephalus with marked enlargement of the ventricles being followed and here again is the suprapineal recess. And again, here's a small massa intermedia. Here's the suprapineal recess on the axial plane. Here's a 4-year-old that came with developmental delay, large lateral ventricle, a large suprapineal recess. It's not an arachnoid cyst. It's just part of the ventricular system. This was a very interesting case that Ahmed showed me of this massive cystic structure in the posterior fossa with the cerebellum being markedly compressed. This was a 60-year-old with very large ventricle. He was shunted many years ago. And I think what happened here, although I cannot prove it, that this is the suprapineal recess that ruptured, and we ended up with this large collection of CSF in the posterior fossa. Maybe developed then into an arachnoid cyst, but I think it all likely started with this markedly enlarged suprapineal recess. Okay, one last possible cause of fourth nerve symptoms. What is the condition on this image? Correct. As Gino says, this is a cavum, not of the velum interpositum, but velum veli interpositi, which when I talk about the embryology and evolution of the ventricular system in another talk, I will point that out. But this was a cavum veli interpositi. Now, here again is a large one which actually extends lower down, and again you can see its proximity to the inferior colliculus and why it possibly could cause fourth nerve symptoms. Here it is on the T2. Here's even a larger one that extends more inferiorly. Notice again it's adjacent to the collicula, to the quadrigeminal plate. And this is even a larger one. Again, notice the flattening of the quadrigeminal plate, and look again at extended into the posterior fossa, compressing the cerebellum with a large extension. Unfortunately, none of these cases I could get any history as far as fourth nerve symptomatology. But again, one of the possible causes of trochlear palsies. What's wrong here? Correct, as Eric says, atrophy, superior oblique muscle atrophy. Everybody's saying that. Nate, Ben. And again, here's the normal atrophy. And again, this is just to show the end result. This was denervation atrophy of the superior oblique muscle, secondary to presumed trochlear schwannoma, which we can see here. Here it is. Notice in the appropriate location where the trochlear nerve runs. And this was the end result. Unique, just one muscle atrophy because of this presumed schwannoma. Now, I'm going to switch topic. Last Thursday was Ben's first day at the VA, where he came to work with me, and the first case we saw, both of us, was this classic case that Pradeep showed us. Anybody but Ben, please come up with a diagnosis. Stroke, that's very good. Nate says a stroke, but I'm not just going to show a stroke. What structure is involved? A very important structure. Correct. Asif mentions the medial longitudinal fasciculus. And that's what it was. Patient had symptoms for 2 days prior to the study. And that brings me to the topic of the medial longitudinal fasciculus, as known MLF. Now remember that I showed this chart before when I was talking about the various tracts going through the brainstem. I covered all of these in my talk on the brainstem, and then I covered the trigeminal lemniscus and the spinal trigeminal nucleus and tract when I talked about the trigeminal nerve, and that left one tract that I did not cover, which I'm talking about today, the medial longitudinal fasciculus. Now we're talking about intranuclear ophthalmoplegia, also known as INO. It's a gaze disorder characterized by impaired adduction in one eye. INO results from a lesion involving the medial longitudinal fasciculus, the MLF, on the side of the impaired adduction. INO is most commonly caused by demyelinating disease and is one of the most common manifestations of multiple sclerosis. Cerebrovascular disease is also a frequent cause of INO. Now, while we're talking about INO, I just want to mention the PPRF that some clinicians will sometimes use, which we really cannot see. It's the paramedium punting reticular formation on either side of the INO, which activates the ipsilateral abduction. It's all complicated relationships, but you may sometimes hear the term the PPRF also when these patients have ophthalmoplegia. So again, if we look here in this sagittal image, this is the MLF. It's a long structure extending from the level of the collicula all the way down to the level of the sixth nerve. And as you can see in this diagram, this is the MLF, the medial longitudinal fasciculus, kind of communicating the third nerve nucleus to the opposite sixth nerve, which I'll be covering in the next talk. And why I'm talking about MLF today, you'll see in a minute. So there's some interruption of these fibers in the MLF causing the symptomatology. And this is like the classic image. When the patient looks to one side, you can see both eyes moving laterally. This is the normal gaze. And here, this eye is able to move laterally, but there's a problem with adduction, and this eye cannot move beyond the midline. So this is a kind of classic image of INO. And I'll show a bunch of cases. It's not an unusual problem. So here's a patient presented with a left INO secondary to a stroke in the MLF region. And you can see here, this is the location. This is the MLF right just behind, in front of the ventricle. And you can see the stroke is in the appropriate location, quite high at the level of the superior cerebellar pedunculus. Another case with abnormal signal in the appropriate location. Patient had a right INO, no recent stroke, may have been a prior one. Many of these patients have diabetes. Here's another patient with a hypertension, diabetes mellitus, had a right INO, and again we see the stroke, and again, here's the MLF. And that's why I'm talking about it now, because it's so close to the third and fourth nerve, it's really hard to separate, as I'll show later. So this is again an INO. Another case of an INO, again, lesion, the stroke. And again, notice this is close, the MLF is close to the fourth nerve nucleus. This is a patient developed a sudden INO after a cardiac cath. And again, we see the tiny stroke, again in the appropriate location for their MLF. Now, this is a fairly recent case. Patient had two hemispheric strokes, which were pointed out by the person who read it, but did not mention this lesion here, right in the midline. And the clinicians were not happy with the symptomatology, that the symptomatology of the brainstem was explained by these two strokes. So they brought the patient back for another study. And again, there's a lot of abnormality here, but do not neglect to mention which was in this location, which was appropriate for involvement of the MLF, which went more with the patient symptomatology than these hemispheric strokes. Now here's another common cause of INO. This is multiple sclerosis lesion, again, in the appropriate location for the MLF. This was an interesting case. This patient came in with a right INO, and we saw that, and all these lesions, and I remember we called the clinicians, look at the enhancement right in the midline, and we said, we think the patient may have MS. It was a younger patient, and sure enough, they worked them up, and this was an MS case. I would say that the majority, a huge number of these lesions involving the INO are not commented on unless you really know that that's an important location, because sometimes there are many lesions. Like here's a case, this patient presented, MS patient was INO, intranuclear ophthalmoplegia. But again, if you look carefully, you can see among all these other lesions, there is involvement here explaining why I have INO, because it's an appropriate location for the medial longitudinal fasciculus. So this was, for instance, low down, and so all along the location of the MLF at the various level. See, here it is, upper medulla, pons, upper pons at the level of superior cerebral peduncle, and even higher at the level of the peduncles. All this midline lesions, all could be damage to the MLF at various levels. And here's an unusual case, Korsakov. It also had an INO involving the medial longitudinal fasciculus. I just wanted to show, because most of the lesions I showed were on the right side, but here's a patient who had a left INO, so it can happen any side. Here's another one with a left INO. Okay, now, why did I want to talk about INO and the MLF? Because here's the issue. Here's an oculomotor nerve lesion, a trochlear nerve lesion, and an MLF lesion. I think it's impossible to really differentiate each one clinically. So already it's a huge success if when we read the cases to at least point out what the lesion may be. And you need the clinician help or look in EPIC to try to see which of these three possibilities is the most likely, because they all look the same. Now, why is it that they're so hard to distinguish? Is we can see on these next few pictures. Here, for instance, here's the aqueduct with a green arrow, and here's the third nucleus, very close to the aqueduct, and here's the fourth nucleus, just at the anterior edge of the periaqueductal gray. So they're very close together. If we look at so the oculomotor nucleus is at the level just in front of the superior colliculus. The trochlear nucleus is just in front of the inferior colliculus. These are very small structures, very close together, as you can see here. And on regular imaging, axial imaging, we're lucky just to get one image through the quadrigemal plate. And unless you have it angled appropriately, it's very hard sometimes to say on regular imaging, are you at the level of the superior colliculus or the inferior colliculus? So again, all these structures are very close together. Again, in blue, the third, MLF in purple, and here the fourth nerve. And the sixth nerve is not an issue, as you'll see next week, because that's way down and it's easier to identify. But the MLF, the third and the fourth, are very similar, and it's really very difficult to separate them unless you have some clinical information to help you, or if you had some very high quality thin T2s, which we rarely ever do at this high level. And this is the last slide for today. Thank you for your attention.